Good morning, everybody. It is October 10th, 10/10/25. I hope you're all having a good morning. I'm Lisa Salberg. I'm your host for Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. And today I am happy to be joined by Dr. Marty Maron, or Marty Maron. Sometimes you're Martin and sometimes you're Marty on here, so we go with what we go with.
I'm flexible.
Good. You're flexible. So Marty, what's going on up in the Massachusetts region in 2025, October? What's up?
It's fall and the weather's good. Leaves are changing. Great time, probably our best time in a way here, I think, at least. Classic New England, getting ready for Halloween. Yeah.
You guys win for autumn. You guys have the best autumn.
We win
just
for
kind of
autumn.
works up there.
We win for autumn, and then we kind of lose otherwise. So after that, it kind of falls
We're pretty
off.
good in August. August is pretty good.
We're pretty good August, but
Pretty good August.
right.
And fall.
Come December, it sort of falls off we don't do so well for a while.
Yeah, Jersey's kind of the same, but we get like May to August, and then like October. October is pretty good here too.
Sure.
Except for the tree right in front of my window dies early, and it's kind of sad, but that's okay.
Yeah.
So it's been a minute since we talked with everybody here watching and listening and learning. And I wanted to do kind of a what's hot and what's new. I want to bring everybody's attention to what we started talking about years ago. Thank you, Harry Lever, generic drug quality, and how it has evolved. And I want to let everybody know that there has not been one, but there have been 2 Senate hearings in the past month on the topic of generic drug quality. It is bipartisan. It is understood that we have a problem and that we must find a solution. Earlier this week, there was a Senate hearing, and when you see the people that were in agreement, it brings a little bit of faith back into our system. We have hardcore right and hardcore left coming to agreement saying we need to work together on this problem. So I'm very happy to see movement. The exact movement includes things like inspecting drugs when they come into the country so we know what we're doing and what we're taking. It also includes putting federal funds and other funds into building up our internal infrastructure so that we can have manufacturing capabilities in the United States. But that also includes we need the API, the base formulas that all medications are made from. We don't make any of that in the United States. And in some cases, it's controlled by one country, and that's China. Some of them are controlled by China and India, and we don't quite know where some of these base ingredients are coming from. So we need to start manufacturing them here, and we need to come up with a workflow for that. And the Senate hearings were very clear on that issue. So it was very exciting to see people moving towards center of, polarized views to hopefully come to some conclusion and bring some legislation forward so that we can improve the quality of generic drugs in the United States. So they listened. It's crazy. Yep. So Marty, that's my great news that we're moving forward on that. What's gone on in HCM science over the past couple of weeks that's got you interested or optimistic?
Well, yeah, I think we talked a little bit about this last time. I think we're still, in terms of, impacts lately scientifically in HCM. I think, we had that big sort of bolus, so to speak, of information and insight, which was really, really big, from the European Society of Cardiology meeting in August, where those 2 sort of really big clinical trials in HCM were presented and ultimately published, both of them in the New England Journal of Medicine. One of them called MAPLE, was looking, of course, at the comparison of aficamten, which is a second-in-class cardiac myosin inhibitor, which is not yet approved by the FDA, but is under review at the FDA for treatment of symptomatic obstructive HCM, was kind of put up against beta blocker therapy in symptomatic obstructive HCM and was shown to be far superior to beta blocker. In this case, the beta blocker was metoprolol for many of the typical outcomes or endpoints that we find important: how patients feel, how patients function, other markers of disease severity. All that improved much greater with aficamten than metoprolol, kind of suggesting again that making a case, I think, for the role of potentially aficamten as kind of first-line monotherapy for symptomatic obstructive HCM. That was the implication, I think, ultimately of that study. And so that was pretty impactful, obviously, because it directly impacts treatment and our strategies around treatment. So that was a huge trial. We gained a lot of information about beta blocker use as well through that trial. And then the other one was the ODYSSEY trial, which was looking at mavacamten, first-in-class myosin inhibitor for treatment of non-obstructive HCM. And unfortunately, that trial was not positive in terms of showing a benefit of MAVA for the primary endpoints of how patients feel and function, was not statistically different than placebo therapy. We talked a lot about that as well. We tried to unpack that a little bit. That doesn't mean that myosin inhibitors may have no role in non-obstructive HCM. Just to again emphasize, there's another big trial that's going to be coming out in the spring, around the spring, looking at aficamten in non-obstructive HCM called Acacia. And so those are different, slightly different formulations and drugs, and slightly different trial designs, et cetera. And so the jury's not yet out completely on myosin inhibitors for non-obstructive HCM. So you have non-obstructive HCM and you're looking for another drug for benefit here. Let's remain hopeful that we may see a benefit still with this second trial, Acacia, with aficamten. Again, that's going to come out first or second quarter next year. Otherwise, I think, there was a Heart Failure Society meeting that just occurred about a week or two ago. Not a lot of new stuff there necessarily, other than there was some evidence for patients with non-obstructive HCM, I should say, that had been part of the aficamten clinical trials before, who got put into kind of what we call an open label extension. So they were in the Acacia trial or other trials, and they get followed on aficamten. And what that study reported was that there was a pretty good amount of evidence right now over a fairly long treatment period that patients with non-obstructive HCM who were on aficamten, there were signals that they were improving in how they feel, and other markers as well, to kind of create some early potential enthusiasm that aficamten may be different than what we saw with ODYSSEY in terms of improving how patients with non-obstructive HCM feel and function. And again, that was an open label extension report, which means that the patients all knew they were taking aficamten. There was no placebo group there. And so just so everybody understands, that's really important, because it wasn't data that was comparing aficamten to placebo. And that's what we really do in those kind of phase 3 clinical trials, to ultimately prove that the drug, in this case, aficamten, does actually provide benefit over placebo. Okay. And so again, that's coming out in the spring, but there's some evidence with this study that I was talking about last week that suggests that creates kind of enthusiasm and optimism, I guess, that around that trial based on the preliminary non-randomized trial. So that's where we're at.
Cool places to be. Things are moving pretty quickly in HCM these days. I will just give a public service announcement, because I wasn't quite sure how I was allowed to say this the last time we talked, even though I knew it was coming. If you were in the Maverick trial or the ODYSSEY trial, and your physician and you feel that you benefited from that trial, there is now a pathway for what's called expanded access. We used to call it compassionate use. So there is a process that your clinician can engage in, that they can request to the FDA that you still get drug. And as long as the FDA agrees, that patient will get access to mavacamten through this compassionate use process through the FDA at no cost. So for those who benefited, we worked with BMS to make this available worldwide to anybody who feels like they benefited. I was kind of going for the Maverick patients because they had about 7-8 years in, but they opened it up to anybody on ODYSSEY who felt that they benefited. So the clinician that was your PI for the original trial must be the one to process the request. And you still need to maintain the relationship with that prescribing PI. And the follow-up will be similar to the REMS program that exists elsewhere. So if you want it, it is available. I just wanted to get that out there. I do have some kind of late breaking news, and I can't say terribly much, but I'm a little optimistic based on what I saw be added to the agenda for the American Heart Association on the Tenaya trial. So they're going to be doing a readout, and I think it could be interesting. So we will be talking about that in November when we reconvene after AHA and we get that data. So stay tuned. There might be some information on gene therapy for myosin binding protein C3 coming up soon. So that was a lot of background data about what's going on in the world of HCM in 2025. So now the theme of the month. The thing that scares people most about hypertrophic cardiomyopathy, I believe, remains the same topic that always freaks us out, and that's sudden death. We can talk about managing symptoms a lot. We can talk about diagnostics. We can talk about family planning. We can talk about all that stuff, but sudden death is kind of the great equalizer that gets our attention. Marty, your dad has done some seminal work in identifying risk factors and helping us get to an ICD generation. But it's 2025. Where are we in understanding sudden death in HCM? Has anything changed? What are the basics? What are we not thinking about anymore? Let's talk about sudden cardiac arrest.
Yeah. So, I think, if we're going to talk about that, I think if we start sort of where we're at the beginning in terms of, I think one major point to make here is that one thing that we have seen in terms of a trend in sudden death. Remember, we've talked about sudden death due to HCM being the most common cause of sudden death in young people in the United States. At least those less than 35 years of age. And so I think what we've seen actually, if you look at the sort of trajectory of sudden death event rates, they've come down over time. Yeah. They've come actually really way down in a way. If you compare where we've been the last 5 or 10 years versus, 20, 30, 40 years ago. And so the sudden death event rates are much less now and are relatively low compared to what they were for many, many years in HCM. And so the question is, what's responsible for that? And I think one of the major reasons is that there's been, an incorporation, an integration of the strategies that many people have worked on in HCM, investigators, and through many, many studies, we've developed a fairly mature kind of risk stratification strategy, right, where we can fairly reliably identify through the presence of one or more what we call risk factors. These are present in a patient's clinical profile based on their test results or history, can identify reliably those patients with HCM that are at the highest risk in the future of sudden death, and therefore provide those patients, using that strategy, protection from that with the implantable defibrillator. Okay.
So defibrillator therapy came to HCM in the late 90s.
Yep.
We put a few in then we put a lot in, and now we're kind of backed off again as to where that balance point is. There's some different philosophies in different countries on who and when and how defibrillation therapy. But I think we've all kind of evolved to some core understanding of what risk factors exist today with strong evidence. So what are the things that come to your clinical observation in a patient that says this person definitely qualifies, might qualify, should be reassured that they don't need? What does that look like from your side?
You mean, what are sorry, just make sure I understand.
Risk factors.
Risk factors, yeah.
Yeah.
Yeah, I mean, I think there's pretty good agreement about what the major risk markers are that help us to ultimately decide if a patient has one or more of those, if they are high risk. And those include, for example, things like family history. So we know that there are high risk families that for a number of reasons, the mutation in that particular family seems to increase risk of an adverse complication, in this case, sudden death, based on the family history. Okay. And so family history of somebody dying, usually young, from HCM is a risk marker for other patients in that family. 2 is syncope, which is a fancy word for loss of consciousness. So abrupt, unexplained loss of consciousness is a marker for increased risk in the future of sudden death. And so that's a second risk marker. A third is there's a pretty strong relationship between the extent of wall thickness, the magnitude, and increased risk. And so when you start to approach extreme wall thicknesses, close to or more than 30 millimeters anywhere in the left ventricle, that's a risk marker. When you've got extensive amounts of fibrosis by MRI, that can be a risk marker. Okay, so that's an MRI-based risk factor. If you have on the ambulatory monitor that most patients will wear as part of their initial and follow-up evaluations, if you have a significant burden of non-sustained ventricular tachycardia, these are abnormal rhythms in the bottom chamber that are together that patients may not feel but can be identified on an ambulatory monitor. If you've got a lot of those, or you have one that's particularly long or fast run of non-sustained VT, that can be a risk factor. And then the other one. Can we
stop on that one for just a minute?
Sure.
This one has been confounding lately because definitions of what is problematic seems to have changed a little bit. So can you talk about how long a run of NSVT and how high of a rate an NSVT is that's concerning clinically, or the repetitiveness of those events?
Yep. And so, we don't perhaps have quite as much information to be as precise as we would like on that question. But where we are in general is that we put greater weight, for example, on patients that have an increased frequency of non-sustained TVs. That means more than 3 or 4 runs in a 48-hour period, consecutive 48-hour period. Okay? Or if one run is long, generally 10 beats or more. Okay? Or if a run is particularly fast run, like 200 beats per minute or more. Okay, those are kind of relatively rough criteria that seem to be associated with even greater risk in terms of NSVT. Okay. So that means that we put a little bit more emphasis if one or more of those frequency, length, or speed are present, we put a little bit more weight on that being predictive of future sudden death when we see it on the ambulatory monitor.
Okay. I'm sorry I interrupted you as you were going through your risk factors and I stopped you in.
No problem. Absolutely. And then we can open up after this, but just to round off the risk markers then, the other ones are a structural change to the heart that is associated with increased risk, which is the development of an aneurysm, a thinning, which is scarred at the apex. And then the other change to structure that is also associated with increased risk is when patients can develop a decrease in the pump function of the heart. When it decreases over time, and we call that we measure that by the ejection fraction on the echo or MRI, when that's less than 50%, that it also identifies an increased risk of arrhythmias as well. And I think that rounds out what we call the major risk factors for sudden death.
So if a risk factor has been identified and a patient is on the fence to ICD or not to ICD, we have a question up here. You've been told you are having NSVT. Did this contribute to your care plan? So I'm not quite sure where that one came from. So we were just talking about NSVT, and that is a decision maker that could alter whether or not a device would be recommended or not. Would that be an accurate way of putting it, Marty?
Yeah, exactly. I mean, I think the idea here is that, again, there's some judgment, but basically the principle is that in an individual HCM patient, the presence of one or more, of those risk markers may be enough to consider that patient, that individual patient's risk for sudden death to be high enough that it would potentially be reasonable to consider that patient for an ICD. That's the principle, okay? Obviously, as part of that, as part of that strategy that I just said, we obviously, individualize things for the patient as well, in terms of their expectations about treatments. We also balance that discussion with the pros and cons of having an ICD, the risks and benefits of that. Something we call kind of a shared decision-making discussion, where we balance what we believe the risk in the future to be for sudden death for that patient against what it means to live with an ICD, including not just the benefit of protecting against sudden death, but also the downsides, which include things like infection, sometimes increased risk for vascular complications, infection, inappropriate shocks. So all of that's in that sort of discussion and is all part of the decision making that involves the first and foremost looking at the individual risk markers to see if a patient has one or more of them to begin with.
So if a patient has one or more,
Mm-hmm.
It's 2025. There's more than one way to skin a cat now. We've got a bunch of different options with defibrillators. So we have the transvenous, traditional, what we've been using since the 90s, dual chamber or single chamber pacer defib box. Now we have SICDs, which are larger and sit outside the rib cage on the side. And now we have EVICDs. So patients are hearing a lot of different terminology. Clinically speaking, how important is device choice to a patient, and what matters and what doesn't when it comes to device choices in 2025?
Yeah. I mean, so there's a number of different kind of considerations that come into play there about device choice. And a lot of it has to do with, things like, certain devices may be associated with a little bit less risk of inappropriate shocks. There's different risks related to other complications depending on the device, related to the leads, or infection, or the ability to provide pacing, backup, what we call pacing if the heart goes too slow. So there's different sort of elements here that involve, different types of benefits and downsides, so to speak, depending on the device. Okay. And so, that also has to be weighed against, therefore, the patient's, certain expectations and desires, and what a patient may be willing to be okay with, and what they may, find, not as acceptable in terms of that. And so that's why that's a complicated, sometimes can be a complicated discussion. It requires, really taking patients through the pros and cons of each of the devices and how that relates to that individual patient's clinical profile and situation, as well as their desires and goals for treatment.
So that brings up a really good point here that Tim was bummed out that he was unable to obtain a truck driver or school bus license with the defibrillator. So there have been some changes from the Department of Transportation in the past maybe 10 years. We had been engaging with them back around 2010, 11 for approval for certain people to be able to get CDLs. It used to be that as soon as you had any left ventricular dysfunction, you were out. But now the guidelines did change that if you have stable HCM and no risk factors, that you can have a CDL. But once you have the defibrillator, they don't allow that. I think it may be a little overkill from my perspective. I think I'd rather have somebody with a defibrillator than somebody who has opted not to have one so that they could drive a truck. So like, what's the decision making here? It doesn't seem to make a lot of sense, but maybe there's some room for some policy changes there. I'm sorry, Tim, that you couldn't hold those positions. That's up to the Department of Transportation, and maybe someday we'll get them to understand the infrequency of a defibrillator discharge, even in HCM, and maybe we can open that up a little bit more. Marty, another question I've been getting a lot of lately is the role of a defibrillator in a young person so that they could participate in athletics. So we know that the barriers of participation in certain levels of athletics has changed over the years, that we're able to keep people a bit safer and have a better understanding of disease. So there's some room there for shared decision making. But should somebody consider putting in an ICD so that they can continue to play their chosen competitive athletic activity?
Yeah, I mean, I think that I'll just say that in general, again, there can be some specific differences and nuances and kind of how to approach that question and decision making here. But I think in general, I think most would agree in terms of experts here that there is less rationale, I think, to put in a device, like an ICD, which carries risks and everything else to it, solely for the purpose here of then providing that patient the opportunity to necessarily play competitive sports. Okay. And I'm not saying that means that nobody should pursue that kind of strategy. I'm just saying that as a principle to sort of begin with, that we generally don't look at that as a primary treatment strategy for prevention of sudden death, to put in these expensive, complicated, somewhat risky devices forever in a patient long term, solely to just protect, not just, but to protect against issues that could occur on the athletic field, which is a different type of scenario where these devices, first of all, have never really been tested exactly to that level for their reliability. There are issues that could come up as well about the devices potentially being compromised during an athletic field or athletic kind of event. So in other words, there's a lot of things to consider here when thinking about this decision making. And I'll say, therefore, it's really complicated and should really be done with this conversation, really be done with experts in both HCM, sports cardiology, kind of thing, so that patients really get the right advice here on this issue. So I think that's where we're at right now.
Okay, we have a complicated question coming up. I'm not sure if we're going to be able to answer this, Lisa. My wife has complex regional pain syndrome, was recently diagnosed with HCM. They're talking about putting in an ICD. We're very concerned. So we've got a comorbidity here. I'm not sure too much about complex regional pain syndrome. I don't have a lot of experience with that. I don't know if you do, Marty. But if somebody has pre-existing condition that might become problematic with ICD, I know I would suggest going to the highest volume program that they have access to, and I would be discussing very clearly with my implant team what the other chronic illnesses are and making sure that my providers were communicating well about how to manage my pain. What else would you recommend for this individual kind of situation of a complicated other medical problem on top of the HCM?
Yeah, I mean, I don't want to weigh in specifically on this, because I don't have all the information, and I'm not really as familiar with that kind of other comorbidity with chronic pain syndrome to be sure here, other than to say that it sounds kind of complex and nuanced, and I think that's a situation where, getting the right advice from experts, both in HCM, electrophysiology, and also from the chronic pain doctors there that are taking care of her, so that there can be a kind of alignment there on what may be the best steps forward here for her for both of those issues in terms of management.
Fantastic.
Yeah.
So thinking about Sudden Cardiac Arrest Awareness Month, and you and I have both seen, I'm going to say this in an odd way, the good and the bad, meaning we have seen people survive cardiac arrest due to technology, being in the right place at the right time, community CPR, AED use, ICD, appropriate discharges. We've seen the positives. We've also seen the negatives. And the person that scares me the most is somebody who says, I feel fine, and I know I have risk factors, but I don't feel them, so I'm not going to get an ICD. I have at least a dozen people I can think of in 30 years that knew they had risk factors and didn't believe them because they didn't feel it. And they're no longer here. They succumb to a cardiac arrest eventually. How do we separate for people, I feel bad and I'm at risk, and help them come to the decision to welcome the defibrillator therapy? How, you've seen them, I've seen them. How do we help people understand risk better?
Yeah. Well, that's a great, it's a great point, and I think that point really does get to, so one of the core issues I think that we have in HCM in general, which is the ability to communicate, experts to be able to communicate in a certain way to patients the context of the issue in the right way that they can then kind of understand and relate to, and ultimately become empowered enough about that to make the right decision for themselves. And so I think that's a conversation that generally occurs best, as we've talked about a zillion times, in HCM centers of excellence. Okay. Because it's in the centers of excellence that you are going to see a HCM specialist that knows how to not just the science, but I think also how to translate the science in a way that it contextualize for patients and will resonate in a way to make these complicated decision-making processes better and easier. Okay. And so that's a great example is the issue of being able to contextualize for patients. Risk of sudden death has nothing to do with symptoms. It has nothing to do with how you feel. It's an electrical based risk, right? It's an out of the blue risk that the electrical system in HCM will fire off in a way that is not normal and is detrimental to a patient, that has nothing to do or not associated with that patient's symptoms. In fact, the vast majority of patients who have sudden death in HCM are asymptomatic. Okay? So taking that major concept so that patients who are hearing about sudden death prevention can understand that it has nothing to do, the risk of the sudden death or the IC has nothing to do with how they feel, seems maybe simple since we're talking about it, but is actually sort of a complicated, contextualized issue here that really has to be conveyed to patients in a very clear way that they will be able to get, so that they can come across that barrier that almost all patients come to the clinic with, which is that risk is associated, no matter what that risk is always associated with symptoms, because that's saying that their disease is significant enough that they're feeling it. And if they're feeling it, then yes, maybe they could be at risk for sudden death, but that is a obviously that's not correct. And so we have to be able to do that in a certain kind of way. And I think you get that, you're more likely, of course, to get that kind of clarity and exchange in the centers. We also, by the way, need additional kinds of tools to help convey that information as well. There are ways of explaining these kinds of risk estimates, to patients that I think go beyond just numbers and having a where we can actually visualize the patients using tools, what we're really talking about in terms of their magnitude of risk. For example, how does it compare to other risks that patients may take, like driving on the highway, or going on an airplane, or scuba diving. I mean, how does the risk of their sudden death risk in HCM compare to other risks that they may have a better way of contextualizing because they're used to thinking about that in that way? And so we need those kinds of tools. We don't really have those to be able to help facilitate some of these discussions, including sudden death prevention, better. And so I think that's something for the future that needs to be developed as well.
I couldn't agree more. I've been doing some slide deck building over the past couple of days, and one of the slide decks that I was working on is shared decision making. And it's very interesting when you look at shared decision making, educational tools for physicians and healthcare providers, and then what's available to the public. And there's a disconnect. And there is no shared decision making tool for hypertrophic cardiomyopathy because it's very complicated. We're trying to advance that initiative a little bit, but it's complicated because each item has its own level of decision making and risk and benefit evaluation. Some of them are short term, some of them are long term, some of them are lifelong. So figuring out how to have that conversation on both sides remains a challenge, and one that I think we've moved the ball on quite a bit. And this podcast is actually one of the tools to help patients make better shared decisions, giving them more insight to different clinicians' points of views, to think through some problems with them verbally so they can watch how we talk about it. Hopefully they'll take some of those lessons and bring them into their clinic appointment. And maybe physicians will gain something from how patients ask questions here. So this is actually a tool to help in shared decision-making. Tales from the Heart is here for that purpose. And I think it's important to think about what it is that is really important to you. And then the bigger problem in 2025, trusting health information. And I don't want to go down political rabbit holes because they're crazy right now. But patients need to know where they can trust the information about their disease state, free from biases that are political or outside of themselves. Making decisions is personal. Bodily autonomy is personal. Your relationship with your chosen care team is personal. Make sure that you're understanding true risk and benefit. I've heard a lot of really interesting concepts about healthcare in the past couple of months, and we all have. If you don't have peer-reviewed, scientifically vetted literature, if you don't have a true, unbiased data set, you can't make decisions. If people are trying to pull things in different directions, it's not going to work. So if you are at individual risk and somebody says you're at risk, I cannot tell you how important it is to know who you're trusting and to follow the instructions of those who are guiding you. I ran into a person in my travels who had lost her brother this past summer. And it
Lisa,
turned out
I got to roll here. I got another Zoom. I have to take it at noon here.
We're 12 o'clock. We're top of hour. I'm going to finish the story with the rest of the listeners. Marty, have a safe trip to China. We'll be missing you at the annual meeting, but we will be sending a video to China and back to us. And we hope you guys have a great time. I'm going to finish the story as you wrap up here. Thank you, Marty. Have a great weekend.
Bye.
So the story here is that an individual came to me at a booth at one of the conferences that I just went to and said, "Oh, my brother has recently passed away of a sudden cardiac arrest. And we've been working with this individual and her sister-in-law to try to help them figure out what happened. Turns out that this individual was informed about his risks and that an ICD was recommended, and they turned it down. They said, no, I feel fine. And that was like 5 years before he actually passed. And it doesn't look like it was revisited. And we have to dig in a little bit deeper. But there was a 5-year window when somebody could have gotten an ICD and didn't. And he passed away young because he didn't understand. I don't believe he understood that this risk was real and it was a permanent situation. Sudden cardiac arrest, if not turned around very quickly, is permanent. You don't get a second chance to make that decision. So I would just encourage you all, if you've been told that you have high risk features for sudden cardiac arrest, that you take your physician's input to light and you follow through. And if you opt not to have a defibrillator, if you opt not to be protected, simply understand what that means and that you can't change your mind if something happens and they can't resuscitate you in time. So it's sudden cardiac arrest is no joke. I've lost multiple family members to it. It changes a family forever and ever and ever. Even though that individual's gone, their loss is felt for generations. So I'm all pro ICD for the right person, but I also know there's some people that it's not the right decision for, whether it be, I had a client once who was in his 80s. He had an aneurysm. He was at high risk, but he was also starting to encounter complications of Alzheimer's. There are worse ways to die than suddenly. So he opted not to get the device. And I get that. And you're all going to make your own decisions, but please make your decisions based on fact and science and validate that you get that information from vetted sources. Our other topic for the month has to do with resilience and mental wellness. And we are still actively working on building out some new programming that will specifically be addressing the mental health needs of the total community. And that is going to be called Hearts and Minds, a mental health network. And we are working with a number of different partners right now to start the process to build a CME education course for mental health providers and start small, build up. That's the goal for Q1 of next year, is we should be getting something out there and at least some beta tests going. So stay tuned for information on that. And then unfortunately, Marty had a bump, but I do have another announcement that I forgot to put at the head of this. We have one more step to do, but we have received IRB approval for our patient registry. We just have an administrative piece that we have to get put into place before we can start consenting everybody. It's just a double two-factor authentication double check to make sure that we are consenting properly. So as soon as that is done, you're going to start seeing your phones buzzing, where we're going to want to talk to you and we're going to want to get you into our IRB consented data set. And then we will be doing some retrospective evaluations of our data set and letting y'all know a little bit more about what the patient experience with HCM actually is in the global. So stay tuned for that. If you are in the New Jersey, New York, Pennsylvania, Connecticut area, and you can take a drive in or fly into Morristown, New Jersey, next Saturday, October 18th, it's finally here, our annual meeting. It's going to be a big weekend. Number one, on Friday, the board has some work to do. So they're coming in on Friday and we're going to do some strategic planning. And then we're going to all let you know what our strategic plan changes have been at the annual meeting. So we'll be talking about that. Saturday morning, we're doing both a CME for imaging and we are doing a patient meeting that will Saturday morning, we'll be starting at about 7 a.m. and we'll be running till about 6 p.m. with our content. And then we swap over and put the fancy dresses on and the fun masks. And we are at the gala, the Unmask the Great Masquerader 3 gala. We are going to be in Morristown, New Jersey for that as well. We're all at the Hyatt in Morristown for that event. And then the very next day, it will be the first time ever we actually have a 5K for HCM here in New Jersey. If you are in the New Jersey area and you want to come out and support us, you can do a 5K run. It is timed. It is an official race. And we also have a 1 mile fun walk for families. So you can come out in either capacity, support us, be there, have fun. We want to give a shout out to our friends at Baker's Perfection who jumped in at the last minute with a nice donation to help us out on that day. So thanks to our old friends at Baker's Perfection. And thank to all of you who have committed your time to make this happen. Big shout out to Emma and Sophia, who've been volunteers sent from heaven to help us out with this. So thank you to them. And you can come out in person and thank them on October 19th at McGinty Park in Morristown. The information to enroll is on our website. And on that note, I got to go do some slide deck work for our meeting next week because I got less than a week to get ready for all of this. It's been great talking to you today on Tales from the Heart, and we hope you stay safe. Remember, Sudden Cardiac Arrest Awareness Month is what we are in right now. That is October. Remember, that means CPR, AED. That means getting those ICDs in if you need them, checking your family to make sure you know your family heart health history and that you're getting people properly managed. Laura, let's see what you have to say here. Thank you. Thank you so much. We're happy here at the HCMA to be able to provide useful services and to make sure that every big heart's journey is heard, documented, and understood. Even those we lose along the way can teach us some amazing lessons. Specifically thinking about my sister Lori and Justin, who we lost this summer, and Esther and Dave and so many others who we've lost along the way. We learned so much from their experiences, but we'd like to learn more from the living. And that's where the patient journey registry is going to really become more important than we ever maybe dreamed of 30 years ago when this whole little adventure started. So really excited that next year is our 30th anniversary. Who would have thought that we'd be this far along in 30 years? So thank you all. And I hope to see many of you in Morristown. There's still time to sign up if you haven't done so already. Please sign up and join us next weekend. Take care.
The Hypertrophic Cardiomyopathy Association would like to thank our sponsors, Cytokinetics, Bristol Myers Squibb, and Edgewise Therapeutics.